Okay, I have started the presentation already, so I'm ready to go. Can you see the presentation?
Yes, we see.
Okay. Hello, everybody. My name is Axel Nierhaus from Hamburg, Germany. I'm working as a clinical intensivist on a big ICU here. We have 142 beds, adult ICU care. And I want to share with you some ideas about inflammation and possible intervention in COVID-19 patients. This is my conflict of interest statement, as you can hear, as you can see. Now, to start, we have to imagine that we have virus invasion into epithelial layers here, like you see on the top left corner. And then you have two ways of immunological reactions. On the right-hand side, you see the healthy immune response with infected cells that are rapidly cleared, and the virus is eventually inactivated by antibodies and T cells. On the other hand, there's also, in many patients, a dysfunctional immune response with excessive infiltration of monocytes, macrophages, and T cells, systemic cytokine storm, or at least cytokinemia, and of course the pulmonary edema and ARDS we see. Now, the pathogenesis prompts immune modulation in COVID-19. If you look at the pathophysiology, it becomes clear that there are a couple of points where you can interfere with immune therapy, for example, with steroids to regulate the immune response in the first phase, as Thomas Müller has explained, or more specifically later when you have data that there is excessive cytokinemia, you can target single cytokines like anti-TNF, anti-IL-6, anti-IL-1 beta, etc., with a variety of agents, only a few of which have been clinically tested, and even fewer have been found to be effective. If you want to target cytokinemia as a whole, because you have the idea that there's excessive cytokines around, then you should probably work out method like blood purification with a variety of methods that are on the market. However, to my feeling and to my experience, which is, as all of us are rather limited with COVID-19, the pro-inflammatory cytokines can be neutralized by antibodies or through mechanical removal from the blood with various devices. And I think it's very important to control the inflammatory response. It may be as important as targeting the virus in the first place. It depends very much on the phenotype of the patient and on the phase, on the immunological phase the patient is in, and this may change from day to day. So we know remdesivir, for example, has antiviral properties. From animal experiments, we know that remdesivir lowers the viral load if it's given early in the disease, if there are viruses still around, so to say. And it's a matter of time, of the time point of the intervention. As you can see here, within 1 day or 12 hours, there is probably a marked effect on the viral load by remdesivir. However, if you move to more than 2 or 3 or 4 days and you start therapy at this later time point, it may be very ineffective, because the processes that make the patient sick have already started independent at this time point from the viral load. So I think in clinical medicine, where we, as a big center, where we get the patients rather late during the disease, it may be much more promising, instead of going antiviral therapies, trying to with virostatic therapies. I think it's much more promising to work with anti-inflammatory therapies, because You have proximal and distal endpoints when you evaluate an antiviral drug. And the proximal endpoint obviously is a reduction of the virus titers. And if this doesn't translate into improved 90-day mortality, then it's nice to have, but maybe it's not very, very important to the patient, because the benefit the patient will receive from any therapy is probably rather independent from the initial viral load. So I think the effect size of the intervention is diluted over time by many other factors, individual factors from the patient. And of course, from a scientific point of view, it's becomes more and more difficult over the course of the time to prove causality in the first place. We see in our patients a clear reduction of immunological competence in COVID-19, as it has been nicely shown here in ICU patients. For example, you see on the right-hand side the expression of PD-1 receptor, which is so to say an exhaustion marker of the T cells, becomes more prominent over time, which means that the T cell system becomes more and more unresponsive and in some patients even incompetent. You see here the ICU patients on the right-hand side, they all express significantly more PD-1 receptors, which means that their T cells are profoundly hypoactivated over time when compared to healthy subjects or non-intensive care patients. So I think there are distinct phases we can observe during severe COVID-19 with clinical symptoms that are overlapping, of course, and with the most severe patients with ARDS, systemic inflammation, heart failure, and markedly elevated inflammatory markers like IL-6 and CRP, which are easily measured, ferritin. They have probably left the viral response phase and entered the host inflammatory response phase, the hyperinflammation phase, which makes, I think, treatment very difficult. As you can imagine, in this late phase, there is no much point in administering antiviral drugs. But I think, as Thomas has hinted at recently in his talk, it's very important to diagnose hyperinflammation and then have therapeutic consequences. Potential therapies, as you know, in the first phase, remdesivir, for example, plasma therapy, anti-COVID antibodies, this is all very much experimental at this point in time. And later, the big question is, what is actually doing the job? Is it steroids, immunoglobulins, IL-6 inhibitors, anti-TNF, plasmapheresis, cytokine elimination? None of these therapies are validated up to now, and I will give you some of very personal experience and ideas what can be done with these patients at this later phase. So I think the point is to get a grip on excessive cytokinemia, not by eliminating all the cytokines. As you all know, we need cytokines for a effective immune response, but I think the point is to cut the toxic edges of excessive cytokinemia, and I think this can be nicely done with absorbent techniques like cytosorb. Here's data on a septic patient recently published in Critical Care by John Inch's group from the Netherlands. They looked at, they compared observed versus expected 28-day all-cause mortality in septic shock patient. And they found out that, interestingly, even if the treatment group had higher lactate levels, higher norepinephrine dose, and lower mean arterial blood pressure and higher SOFA score, even if they were much sicker than the compared group, there was a clear benefit for therapy with cytosorb. This was retrospective data, but a very interesting statistical way of analyzing retrospective data, and I think these are valid valid data from actual clinical cohorts. The data from Spain, 7 patients with cytosorb in COVID-19 showed essentially the same, a marked reduction of ferritin, D-dimers, IL-6, CRP, and enhancement of the oxygenation index, as you see here. And there are data from Germany, also from Freiburg in the south of Germany, with cytokine absorption, without cytokine absorption in red. You see a marked reduction of IL-6, pro-inflammatory cytokine, when using cytosorb in VV ECMO patients. This has recently been published as a short report in Critical Care. Now, to show you some of our own data in Hamburg, fortunately, we didn't have very many patients who were very sick, but the patients on the ICU, we have a cohort of, at this time it was 63, now it's a little bit more, but here's the first analysis of our data locally here. Patients who did not survive as expected were older. They had higher SOFA scores, they had higher subscores, they had clearly markedly higher IL-6 levels and PCT and mid-regional proadrenomedulin, a marker of vascular and endothelial integrity, and they also had lower lymphocytes. So we observed over the observation period here of 10 days after admission a clear separation of survivors and non-survivors. Non-survivors are red, survivors are green, and as you can see, especially here in the IL-6 panel here, this is a logarithmic scale. The non-survivors had at all time points much higher IL-6 levels than the survivors, which indicates that there is indeed high cytokinemia, if not a cytokine storm, but it's a very, very hard breeze, I think, we observe here. And this was true for ferritin, procalcitonin, and of course also for the number of lymphocytes. You see the non-survivors on day 1 already had lymphopenia, which during later analysis turned out to be a very strong predictor of poor outcome. If you have patients with low lymphocytes over the first couple of days, then survival becomes more and more unclear. MR-Pro-ADM, this endothelial vascular integrity marker, again a good marker for outcome in our cohort, and it also indicated the risk of a patient to become dependent on renal replacement therapy. Those patients with high pro-ADM levels in the first 48 hours had a 10-fold risk to have to be put on CRRT over the next 96 hours. So this again was an interesting finding, I think. So observing that, we started with a single center prospective study, the CytoCov-19, which is still running. And we hope, of course, we don't get all the patients we need for this. But if we do, we have a protocol here, as you can see, confirmed COVID-19 patients with refractory shock, vasopressor therapy, no adrenaline dose above 0.2 mics per kilo per minute. IL-6 should be above 500, and they should have indications for any extracorporeal therapy, be it CRRT or ECMO. And these are the exclusion criteria here. The primary endpoint for this preliminary single center study would be shock reversal as defined here. This is what we, by the way, a picture of one of our patients on our unit. This is what our setup actually looks like on one of the ICUs. Now, so far we have analyzed 10 patients, 5 patients treated with either ECMO or CRRT, and 5 patients not treated with cytosorb. And as you can see, IL-6 in the treated patients in yellow doesn't reach very high levels. It's controlled from day 1 on. And the same is true for procalcitonin. The untreated group in gray goes up very high to very high levels, and noradrenaline could be lowered in the treated patients in yellow also within 1 day after establishing cytosorb therapy. We would use cytosorb daily. We would change the adsorber once daily and observe any kind of benefit in terms of shock reversal. And if this shock reversal is sustained for more than 24 hours, we would stop therapy with cytosorb. This is the current learning by doing, so to say, protocol. We use a passive setting, post-pump to pre-pump. This is where we would insert the cytokine adsorber system. Either we go after the oxygenator here or before, and then have a passive blood flow through the cytosorb column, and then go back before the centrifugal pump. Or in some cases, we would also use the hemofiltration, hemoperfusion pump system, and use ports, pre-pump ports to use the additional external CRT pump, for example. This is the typical setting in our patients. Now, to sum this up, the cytosorb can be used, as you know, for many conditions like pancreatitis, burns, sepsis, of course, rhabdomyolysis, and systemic inflammation of non-infectious cause, influenza, and maybe in future COVID-19, as long as there are measurable high levels of cytokines, of course. This should be, I think, the prerequisite. If you enter a patient into therapy with cytosorb, then you should actually have high levels of cytokines, otherwise it may be in vain. So to my experience as a clinician, severe COVID-19 resembles septic shock in many ways. There's pro-inflammation, there's hypocytokainemia, there's also immune exhaustion very early, as I showed with the data with PD-1 and the lymphopenia. And there's, of course, a distal organ damage, either secondary to direct viral lesion or secondary to systemic inflammation. A diagnostic panel to clearly describe the patient who would benefit most from, for example, cytokine elimination therapies has not been validated. And of course, therapeutic intervention for COVID-19 are under investigation, as you know. And I think depending on the phase the patient is in, antiviral, anti-inflammatory, and pro-immunological, pro-immune interventions should be also considered in the future. We have many lessons learned from bacterial sepsis, and I think the potential for cytokine elimination methods for like cytosorb is very high, and we are eager to share data with other centers if they have similar experiences. With this, I thank you very much for your attention.
Thank you, Dr. Nierhaus. Very interesting data about cytosorb, and some questions maybe from audience. If no questions, I have one. I see that Thomas here too. So questions for you both, for Thomas and for Axel. What do you think about second wave of COVID? This is more dangerous or less dangerous? Because a week ago there was also conference, and some speakers from New York and some speakers from Pennsylvania, they said the second wave in the United States is more dangerous than before, because more patients on ECMO, more patients with very very resistant to treatment of RDS and things like that. What do you think about the second wave and dangerous?
Well, I think we have a different situation here, at least in Hamburg. The patients who are infected are much younger. They are less severely ill, but we are at the beginning of the second wave, and I don't want to know what's happening if all the elderly patients we had in the first wave will become sick and will have big problems with lung failure, etc. So far, we are rather lucky in the international comparison, but I'm not sure if this is the end of the story. I don't know, Thomas, what do you think?
I agree with you. Yeah, at least my hope would be that if a second wave should come, we have much more experience by now. We are better prepared. We have some smaller treatment options. So my hope would be that we could cope better. My hope is actually that we can keep it down until we have a vaccination. But for example, we have reconvalescent plasma stored for 100 treatments. We have high dose with high dose titers. So I think we are better prepared than for the first wave.
Let me ask you a question, Thomas. When you told us that steroids should be used only in very select patients and infection should be ruled out, how would you treat patients who have reactivation of viruses, like many patients who are on mechanical ventilation will experience, like HSV and CMV? Would we think they should not be treated with steroids?
Hard question. At least I would be far more, I would decrease my steroid dose. This would be for me an indication that the patient is not able to clear his virus anymore. So if you have CMV or HSV coming up, I would decrease my steroid dose. I think the more important role is early to avoid this overreaction.
Yeah.
If I would go to a hospital now with COVID-19, when I develop need for oxygen, I would go for remdesivir, I would go for dexamethasone, and I would go for convalescent plasma.
Thanks. And we have one more question from the audience, please.
The question for Dr. Axel Nierhaus. If I use anti-cytokine sorption technologies, it's more safety than non-specific immunosuppression therapy, because sometimes we can see a dramatically reduce of inflammatory cytokines with negative effect. And a lot of guidelines or recommendation, especially in early period of COVID infection, with recommendation for absolutely with the immunosuppression therapy, non-specific.
Yes, if I understand you correctly, I may answer like the nice thing about Cytosorb, I think, is that it's so unspecific. It's just, absorbing anything depending on the concentration it sees. So it absorbs all sorts of things up to the molecular weight of around 50 kilodalton. And I think because the dysregulation of the immune response, you wouldn't know what mediator exactly you should target with an antibody. And I'm very reluctant to say, well, target IL-6 and then you have solved the problem. The immune response is so redundant and there are so many shortcuts and pathways that I think there will never be a single drug addressing this very broadly dysregulated immune response. So the more rational approach, I think, should be to get rid of the toxic peaks and let the rest still be there and do their job.
Okay, more safety than non-specific immunosuppression therapy.
Maybe.
Thank you.
So, thanks a lot for our international speakers from Germany. Thanks, Dr. Nierhaus. Thanks, Dr. Muir. I think we will see you again, maybe next year on the ELSA meeting or Euro ELSA meeting. And I hope that the COVID will finish, and we will see you not only in internet, but in Russia or in Germany.
Thank you for the invitation.
Yeah, thank you from my side as well. All the best
Thank
for your
you.
meeting.
And we're back to our